introduction. It gives me the greatest pleasure to introduce Dr. Erik Imel, coming to us from Indiana to talk to us about evaluation of the child with Rickets. Welcome.
Hi, everyone. Thank you. It'll be hopefully fun to share with you today. It's nice seeing a lot of friends that I know from all over the place on the list of people attending today. So today, my goal is to sort of give a very broad overview of Rickets as a differential diagnosis, or different things to think about as you're evaluating a child for potential Rickets. I'm going to try not to go into terrible depth about treatment of any particular form of Rickets, but I think it's actually very important to know that making the correct diagnosis of the correct form is going to be critical to applying the most appropriate treatment for any given patient. Here are my disclosures, and I'm going to start out with just a couple of quick cases to start with. So first, this is a 10-month-old, exclusively breastfed African-American girl that presented with some delay in motor milestones, and her family had noted her legs were starting to be bowed. You can see bowed legs when she's being sort of held up here, widened wrists. She has some flaring of the costochondral junction, consistent with a rachitic rosary, and the flaring and widening and cupping appearance of her wrists there. The other case is a 4-year-old girl who presented with short stature, a waddling gait, and bowed legs, and she was being evaluated by an orthopedic doctor who did X-rays and then recognized the features of Rickets, had done some initial labs, and sent her on to me. So Rickets comes from an Old English word called wricken, which means to twist. There are some possible case descriptions in sort of the more ancient world. The most clear early medical descriptions were in the 1600s, and during the Industrial Revolution, there were a lot of underprivileged infants in cities that were manifesting with Rickets, and this picture is one from Glasgow, I believe. The clinical features that we see, most classically we expect bowed legs, but sometimes these only happen after weight bearing starts. You can have widening of the wrists or ankles, flaring of the costochondral junction, as we showed earlier, frontal bossing, as this picture indicates, as well as decreases in linear growth, delays in motor development, sometimes weakness and irritability or bone pain. Some forms of Rickets can cause hypocalcemia, and in those settings, the symptoms could be severe. The radiographic findings that we're looking at are typically widening, flaring, lucency, and separation at the metaphyses, as shown on these X-rays. You can have bowing of the lower limbs and torsion of the long bones in the lower limbs as well. The radiographs that we usually use to evaluate Rickets are looking at the knees, the wrists, and the standing lower limbs. But we need some additional history, and I would not just assume that patients have routine vitamin D deficient Rickets, although it's by far still the most common. You want to ask about, their general dietary intake of sources of calcium and vitamin D. Are they on especially restrictive diets, which often happens in very picky children, or sometimes in children with autism? Are they getting supplementation, or do they have any history to suggest malabsorption? And then look at family history. Family history of Rickets or other mineral metabolism disorders is very, very important. And it's also good to recognize that a negative family history does not rule out a genetic cause. Family may be more mildly affected, and so the diagnosis could be missed. Some forms have incomplete penetrance, and so the immediate family members might not have manifested. There are also obviously recessive forms and spontaneous new mutations that are all relevant. My typical laboratory evaluation for most patients with rickets, it's really sort of the top half of this that's the most important: calcium, phosphorus, creatinine, alkaline phosphatase as a bone marker, and the 25-hydroxyvitamin D levels. The PTH is generally elevated in nutritional rickets. It's also often elevated in other forms. And then you look at some of these other factors more when you're trying to find that they don't fit nutritional rickets exactly. It's also important to know your age-related normal ranges, and I can't stress enough that you can't assume that your clinical laboratory is giving you an appropriate age-related normal range. And so as you can see here, the adult normal range for phosphorus is much lower than the infant normal range for phosphorus. And so I have still seen patients whose diagnosis was delayed because their doctor had checked at a lab that was giving them adult normal range. Again, likewise, the normal range for alkaline phosphatase is considerably higher in children than adults. So looking at these two cases, the first case, 1A, had low calcium and phosphorus, high alkaline phosphatase, very low 25D, and a high PTH. And not surprisingly, in this setting, had a low urine calcium, and this is consistent with vitamin D deficiency. The second case, the 4-year-old girl, had a low serum phosphorus, but normal calcium, normal 25D levels, and had a 125D that would be considered inappropriately low in response to the phosphorus. It really should be high in response to hypophosphatemia. And that's a clue to the underlying mechanism. And so this patient also has a low TMP, which is a way of looking at renal phosphate handling. If the TMP is low, you're wasting phosphorus, so to speak. And this is just looking at those, the general categories in those cases. In vitamin D deficiency, calcium and phosphorus can be low or normal. Obviously, the 25D is low. It's important to know that the 125D can be anything in vitamin D deficiency, so it cannot answer that particular question. And it's more useful if you're trying to evaluate patients when their 25D is normal or they have a dominant hypophosphatemic component. So in XLH, you have a low phosphorus. The 25D is usually normal. PTH can be high, but it's not always. And the 125D is low or normal in the setting of XLH typically. And you have a low TMP consistent with phosphate wasting. So when you look at rickets, what are the most common causes? And nutritional rickets is still by far the most common cause. I adapted this from some data in a Danish paper. It's not actually a figure that's provided there, and I recategorized some of them to fit under nutritional rickets because there were different reasons for nutritional rickets. But again, the vast majority are nutritional vitamin D deficiency rickets. Hypophosphatemic rickets is the next most common, and most of those are going to be X-linked dominant hypophosphatemia, or XLH. Dr. Carpenter taught me many years ago to break down rickets into the calciopenic forms and the phosphopenic forms. And again, the calciopenic forms are by far the most common because vitamin D deficiency is the dominant form there. And you have to look at intake deficiency, GI disorders, malabsorption. You can have isolated calcium deficiency, but that is rare. And then there are also less common genetic disorders of vitamin D metabolism. On the phosphopenic side, XLH is the most common, but there are many other genetic forms, and we'll touch on several of those as we go. And then you can have insufficient dietary intake or insufficient dietary absorption of phosphate, but that's a less common cause. Remember, like I said before, to assess vitamin D stores, you want to measure the 25-hydroxy-vitamin D because it has a long half-life. And I reserve the 125D measurements typically for when I'm trying to assess them and their 25D is normal already, or they, like I said, have a dominant phosphate phenotype. Or basically when things are more puzzling. The risk factors for vitamin D deficiency we should all be familiar with, which include family histories of vitamin D deficiency, but also risk factors for low sun exposure, high latitude, they don't go outside, dark skin pigmentation that impairs vitamin D production, as well as low dietary sources and history of malabsorption. When you're treating nutritional rickets, I typically use between 2,000 and 6,000 units of vitamin D a day for 3 months or more, depending on how long it takes to normalize their levels. You can use higher doses. I've been cautious about that because sometimes patients get away from you and then they keep taking higher doses and then come back with vitamin D toxicity, which is not a great outcome. They often have a requirement for calcium supplementation as well. And you have to monitor them, like I said, to avoid overtreating, but then some patients with severe malabsorptive problems need chronically higher doses. I monitor at least monthly serum for calcium and phosphorus, look at the urine calcium to avoid hypercalciuria. If they have a frank hypocalcemia at the beginning, I want to monitor their calcium more often because I want to do that for safety to try to normalize their calcium. It's important to remember the alk-phos may transiently rise before it starts to normalize. But by 3 months, most of the time you can get patients' 25D levels to be normal and their x-rays should be showing improvement in the rickets. Although changes in the shape of bowing deformities may take longer. So some other rare causes. Vitamin D dependent rickets type 1 is a deficiency in the enzyme 1-alpha hydroxylase. So as such, they don't activate vitamin D and the 125D is low. And that results in low calcium and phosphorus. And the rest of the features are generally similar to rickets, except the 25D is typically normal. I do want to say now, before I forget, that all of these non-vitamin D deficiency forms of rickets can be confused when the patient also has vitamin D deficiency. So sometimes you have to start treating them as if they're vitamin D deficient, and then when their labs don't get better, you have to dig further and figure out that, okay, this was not purely vitamin D deficiency, this was vitamin D deficiency on top of a background of a different genetic cause. These patients have to be treated with calcitriol or an other activated form of vitamin D because they don't make calcitriol properly. There's another rare form, vitamin D dependent rickets type 1B, which is due to a 25-hydroxylase deficiency. I think there are a very small number of people reported with this. And it's actually kind of hard to differentiate from nutritional rickets because they will have low 25D as well because they can't 25-hydroxylate it. The 125D, again, is variable. And the signal here is usually that there is a family history that might make you dig a little bit further, or when you try to start treating them with regular vitamin D sources, their 25D fails to rise. And so these patients can be treated with calcitriol and calcium, or you can give calcifidol, which is a 25-hydroxylated form, to bypass the defective step. Vitamin D receptor resistance is an interesting one. It's often associated with alopecia because of the involvement of the vitamin D receptor in hair follicles. They have deficiency in the receptor or its function, and consequently can have quite low calcium and phosphorus. They will frequently have elevated 125D levels, and they need to be treated with calcium, especially sometimes requiring IV calcium. And the response to getting high doses of either vitamin D or calcitriol is a little bit variable and probably depends on the residual receptor functionality. All right, I'm switching back over to phosphorus. And the one thing you need to know when you're evaluating phosphorus is how to evaluate, are they having renal phosphate losses, or do we need to know some other cause of chronic hypophosphatemia? So I think of the TMP, transport maximum of phosphorus, as conceptually the serum phosphorus level above which you begin to dump phosphorus in your urine. So if your serum phosphorus is frankly low, you shouldn't be dumping phosphorus in your urine. And you should be really trying to conserve as much phosphorus as possible. So this can be assessed using a classic nomogram that was published in the Lancet in the 70s. It does not go as high as the normal range for children, but you will reliably detect low TMPs this way. There's also a equation that is probably a little bit more reliable in children. The normal range for TMP is, at any given age, roughly approximates similar numbers to the normal range for serum phosphorus at that age. So if you have chronic hypophosphatemia and you're having an appropriate renal conservation response, your TMP will be high or high normal. And this indicates an intake deficiency, either dietary phosphate insufficiency, phosphate binders, some general malabsorption, or insufficient availability of phosphate from various dietary sources. If your TMP is low, then you have evidence of renal phosphate wasting or just renal phosphate losses. And those I further break down into whether they're caused by high FGF23 or inappropriate FGF23, or whether the FGF23 is appropriately suppressed and it's more of a direct renal problem instead of a hormonal problem signaling the kidneys. So the 4-year-old girl I talked about before, this is just different views of her same x-rays. She ended up, despite her negative family history and her tall parents, had a PHEX mutation. So PHEX deficiency is the cause of X-linked hypophosphatemia, the most common cause of hypophosphatemic rickets. And when you don't have PHEX, the osteocytes make more FGF23, as seen on the left, where that results in high intact FGF23 levels in blue here as compared to the controls in purple. Now, what does that do? High FGF23 levels downregulate renal phosphate reabsorption so that more phosphate goes out in the urine. It also downregulates 125D activation, and so that's the mechanism whereby we fail to increase 125D in response to the low phosphate in this condition. In children, XLH really looks a lot like nutritional rickets in terms of its manifestations of rickets and osteomalacia and leg deformities. But it's got the disadvantage in that you can pretty easily cure nutritional rickets, but XLH, you have the problem for your lifetime. And there are some additional features that happen, continue to be a problem as they get into adulthood. And that includes insufficiency fractures, tooth abscesses as illustrated here on the bottom or in the middle of the slide. And they get calcifications of ligaments and tendon insertion sites. And so you get enthesophytes and osteophytes in the spine, the hip, here's the knee and the ankle. And a lot of the adults have osteoarthritis. The medical treatment for XLH, there are really sort of two options now. One is a combination of phosphate salts plus active forms of vitamin D, such as calcitriol or alpha-calcidol and things like that. But you never want to treat those patients with phosphate alone because that really, one, doesn't work, and it causes the PTH to really go up high. And now, since 2018, there's been an approved anti-FGF23 antibody for monotherapy called burosumab. And I'm not going to go into details on those that treatment because Dr. Carpenter nicely covered that for the group recently. There are a few autosomal recessive forms of hypophosphatemia, and they are very rare and biochemically look like XLH, or at least the FGF23 mediated ones do. And that's because they're mediated by high FGF23 production. And there's three main genes that are noted here. One is DMP1, One is ENPP1, which is associated with generalized arterial calcification of infancy, but some of those patients develop hypophosphatemia due to high FGF23 levels. Mutations in a gene called FAM20C, which causes Rain syndrome. And patients can have cerebral calcifications, long bone osteosclerosis, and some other dysmorphisms. But there are patients with this mutation who are reported to have a more of a hypophosphatemic Rickets phenotype instead. FGF23 itself was discovered in studies of an autosomal dominant hypophosphatemic Rickets kindred. This is a proband in the kindred that Dr. Econ studied. She was 14 years old and presented with severe bone pain and pseudofractures in her femurs and in her ribs. It's biochemically very similar to XLH, but it has incomplete and very variable penetrance. And what I mean by that is sometimes patients develop phosphate wasting and rickets and all of those manifestations as children. Sometimes they are completely normal while they're growing, and then as adolescents or adults develop late onset renal phosphate wasting and symptomatic osteomalacia, and they can be actually very severe when they have those symptoms. And it can be waxing and waning. So what do I mean by that? Well, before I get to that, the FGF23 mutations in ADHR impair cleavage at a cleavage site. So normally some FGF23 is cleaved. There's some evidence that this is probably an important regulatory step in keeping your intact levels from being too high in certain situations. But in ADHR, they will preferentially secrete the intact FGF23. But this illustrates two people, one's in blue and one's in purple, and the intact FGF23 is on the left and the phosphorus is in the graph on the right. You can see they both started out with low phosphorus and high FGF23 levels. The one in blue persisted with high levels, actually because she was being treated with calcitriol and phosphate. Her levels of FGF23 actually went up further. The one in purple actually spontaneously normalized her FGF23 and then also normalized her phosphorus levels. And we did a study where we found that the patients who were manifesting hypophosphatemia and high FGF23 levels had iron deficiency. And in general, if you didn't have iron deficiency with ADHR, they were normal. Their phosphorus was normal, their FGF23 was normal. And so we did a prospective trial where we treated patients with oral iron, and you can see here that those who were frankly iron deficient, their ferritin came up into the normal range, and during that time period their intact FGF23 came down and their phosphorus became normal. But those patients who had pretty normal ferritin levels actually didn't really have elevated FGF23 levels, and their phosphorus was sort of just on the edge there, and they stayed in the normal range. But this is important because here what we're saying is that if they have iron deficiency, if you treat the iron deficiency for ADHR, it appears that might eliminate the rest of the problem just by treating an underlying deficiency. We're not advocating for high iron levels though, because that has its own set of complications and problems. There are several non-FGF23 mediated examples, and as a general rule to try to capture them, it's important to know that they often have hypercalciuria and or additional renal losses of other solutes. And so it's important, especially in the absence of a family history, to consider that possibility that they might have a different source, a different non-FGF23 mediated cause, which are much less common. One notable one is hereditary hypophosphatemic rickets with hypercalciuria. It's due to recessive mutations in one of the main sodium phosphate transporters in the kidney, SNAPP2C. And so they have renal phosphate losses, and they do compensate by making high 125D. Now that may be partly mediated because FGF23 is appropriately suppressed. But as a result of the high 125D, they are hyper-absorbing calcium in the gut. And so they have a lot of calcium throughput in the kidneys, and are at high risk for nephrocalcinosis and nephrolithiasis. One of the interesting things is that the heterozygous family members also seem to have higher risk of nephrolithiasis, even if they're not, frankly, hypophosphatemic. And this is one of the rare times when it may be appropriate, or where it is more appropriate to treat with phosphate alone. You don't need to give these patients calcitriol because they're also already very high for calcitriol. Just recently, I think the electronic publication was in December, it's listed as Impress and JCM, a group reported a different autosomal dominant kindred, 3 generations that had hypophosphatemic rickets, and they screened for all sorts of other mutations, and all they found was a change in SGK3, which is a kinase that's in a lot of different tissues. The exact mechanism for it causing hypophosphatemic rickets in this population is not, in my mind, entirely clear, but some cell culture-based studies suggested that it upregulates NaPi2A activity to stimulate phosphate reabsorption. And so in the absence of SGK3, that NaPi2A activity is somehow impaired. The mice have low FGF23 and low 125D. The humans in this case report actually had normal FGF23 and low 125D, except for one patient who was frankly iron deficient, had a slightly high C-terminal FGF23. So the authors concluded this was not FGF23 mediated. In my mind, this may fluctuate. We may learn some more things over time if we see more patients with this. And then there are several Fanconi syndromes that I'm sort of lumping all together. Various genes or acquired conditions, some drugs like tenofovir, that in general cause renal losses of multiple things, multiple substrates. And so it's quite common for them to also have aminoaciduria, glucosuria, even with a normal serum glucose. Calciuria occurs in several of these. And so it's important to evaluate and consider other things in the urine. Look at their bicarbonate and look at urine for protein and amino acids and things. Dents disease is an X-linked recessive form. There are mutations in chloride channel 5 or also mutations in OCRL1 that end up impairing lysosomal trafficking in this condition. And in the kidneys, this results in hypophosphatemia and hypercalciuria. They do have a high 125D response generally, and they have a dominant proteinuria effect, or a fairly dominant proteinuria effect. And chronic kidney disease is a major complication in Dents disease, just the underlying disease. And again, another condition, nephropathic cystinosis, results in stored cysteine and lysosomes that cause damage in many tissues, including the kidney, and resulting in Fanconi syndrome and rickets, and eventually chronic kidney disease. And then the last rickets type of thing I'm going to talk about is rickets with low alkaline phosphatase. And this is one of those places where having an appropriate pediatric normal range is important, because you might think somebody had a normal alk phos because you were using an adult range when actually it was frankly low. And so hypophosphatasia is an important thing to catch, because the treatment is completely different from the rest of rickets. And I know recently Dr. White gave a thorough covering of that topic. So that's the end of this main part of the talk. And I think we talked about opening it up for questions.